Cocaine's a hell of a drug.
This is Jim Pruitt, and you listen to another episode of the Pharm So Hard Podcast.
So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
What's good, fam? It's your host, Jim Pruitt, aka PharmD and ED, and I'm bringing you another episode of the Pharm So Hard Podcast. And today, I have another special episode for you guys, and I'm going to be joined by my PGY2 resident, and she's going to talk to us about data. But before we get into that, let's get into what we're talking about today. Beta blocker use and cocaine-induced chest pain. That's right, cocaine is a hell of a drug, everyone. And this is what we're going to talk about. The old saying, you cannot use beta blockers in cocaine-induced chest pain. But before we get into that, of course, I have to shout out a few things, guys. The PACU is coming soon. That's right. Pharmacy and Acute Care University is coming soon. I have everything set to drop for you guys October 4th. So be on the lookout. Go to the show notes and check that out. If you look at anything with Pharm So Hard or Pharmacy Friday Pearls over the next few weeks, you're going to see it. And this is going to be my premium website, guys, my premium membership, where I'm bringing all the experts together to give you more in-depth information that you need to be the best practitioner you can be, and to give you some phenomenal resources so you can save yourself time that you could be doing making yourself smarter. So definitely go and check out pharmacy/acutecareuniversity.com. Again, that's pharmacy/acutecareuniversity.com. And check it out and get on that email list so I can give you guys more sneak peeks into the membership. Cocaine is the most illicit substance in the U.S., and cocaine-associated complications, most commonly chest pain, accounts for roughly 40% of all drug-related emergency department visits. And cocaine can actually cause chest pain or acute coronary syndrome, or ACS for short, by increasing myocardial oxygen demand and decreasing the oxygen supply due to vasoconstriction. And this can occur because cocaine blocks reuptake of norepinephrine and dopamine, causing an accumulation of catecholamines at the postsynaptic receptor, therefore acting as a sympathetic agent. It's also going to work on those alpha receptors, causing calcium influx into smooth muscle, and this can lead to coronary vasoconstriction. But the interesting thing of all of this, the use of beta blockers in cocaine-induced chest pain is super controversial. I mean, we've been hearing about this from the 60s and 70s, and everyone's been passing along in textbooks, with early studies suggesting that beta blocker uses in this population was harmful because of the unopposed alpha stimulation, leading to an increase in blood pressure and coronary artery vasoconstriction. Yeah. I've been hearing that stuff for forever now. I want to see what we can do about this cocaine-induced chest pain. And is beta blockers really that bad? So two of the big agents we're going to talk about is labetalol and propranolol. Metoprolol is used quite a bit, guys, but from a historical standpoint, it makes it pretty interesting to talk about just these two agents. So we have labetalol, which is traditionally given at 0.25 mg per kg IV, or you can give anywhere from 1 to 200 milligrams PO. Onsets can be rather quick, with a 5-minute onset and a half-life being about 6 to 8 hours, and you have to look out for some things like orthostatic hypotension, bradycardia, dizziness, and of course fatigue. And the weird thing about beta blockers is that they can mask hypoglycemia. Not a really big thing that we care about right now, but something to keep in mind. For my nurses out there, when you're giving labetalol, you want to give this over 1 to 2 minutes. Again, depending on what dose you're giving, because you want to have a rate of 10 milligrams per minute. And when it comes to the receptor activity, it's super duper important to mention that you have beta 1, beta 2, and alpha 1 activity. So you're not going to necessarily have that unopposed alpha when given labetalol, because it's one of the better antihypertensive agents because it has multiple receptor activity. Now let's cross over to one of the old drugs, propranolol. Usually we see this given at 60 to 120 milligrams daily, or you can give anywhere from 0 to 1 milligrams IV times 1. And interestingly, you can give it IV or PO, or maybe even intracoronary. More for that later. The onset's going to be within 5 minutes and have a half-life of 3 to 6 hours. And you can have some of the same side effects that we talked about with labetalol. So some things to look out for this. You can push this over 1 minute. And when it comes to receptor activity, it only has beta 1 and beta 2. It's missing that alpha. So Kailey, get into some of that data for me.
So I think one of the most interesting studies that I read looking into this topic is really one of the studies that was first done that most people reference when they're talking about the unopposed alpha stimulation when referring to beta blocker usage in cocaine-induced chest pain. And so this study was a prospective randomized controlled trial that included healthy volunteers. And so essentially they took these patients and split them into two groups. One group received intranasal normal saline, and the other group actually received intranasal cocaine. They used 2 milligrams per kilogram in these patients.
So they're giving these people intranasal cocaine just casually as they're doing the study in the 90s? All right, I see how this is. But keep going, Kailey. I know it's some people that's super professional that don't want to hear me talk.
Furthermore, they actually ended up giving intracoronary, yes, you heard that right, intracoronary propranolol.
Wow.
To these patients. And then within the study, they actually found that overall, it helped reduce their pressures, but there was an increased coronary vascular resistance in the patients that received the intracoronary propranolol. It wasn't a very large study. There was 15 patients total in each arm of the study, and not all of them received IV propranolol. Essentially, it wasn't in all of the coronaries that this increased vascular resistance was seen. It was really just in one of them, so not even statistically significant in, as a whole, but it's definitely an interesting trial and was pretty cool to read.
Cocaine is a hell of a drug.
And then one of the other interesting studies was more recent, so it was one of the meta-analyses that was done in 2014. And so it was basically a retrospective review and meta-analysis looking at the outcomes of patients experiencing a myocardial infarction that received a beta blocker at any point. And so essentially the majority of patients in the study they found that were cocaine positive that had a myocardial infarction and received beta blockers showed no difference in hospital mortality. Furthermore, kind of looking at this, there was quite a few different beta blockers included, but overall they were able to see that there was no increased risk of any toxicity or any issues associated with beta blocker usage.
So basically what you're saying is that my entire pharmacy school and first part of my career is a lie. Great. Thanks for everyone who told me that beta blockers were like the freaking devil when it comes to that. But I'm going to go ahead and stop it here. I know we have a few more studies that we can talk about, but realistically, I think that really hits it for me. I think it hits it for this episode. So we're going to go ahead and close out there. Kailey, thanks for coming on and giving us a little review of the evidence. And thank you guys for listening to another episode of Pharm So Hard. This has been, it's been a fun episode, but go check the show notes out. I got a ton of the stuff there. And again, just really thank you guys for all the support you've been giving us over the years, and for us to be consistently a top 5 emergency medicine podcast, the top 3 pharmacy podcasts. Really just shows the support you guys given us over the years, and we look to do great things like the PACU. That's gonna be another big thing for me. In March, we have the Empower Conference that's gonna be going live, the first of its kind emergency medicine pharmacy conference. It's gonna be super cool with all the smart people, the great things. So go check us out, pharmsohard.com. You know where to find us on social media, pharmso_hard at Twitter, Pharm So Hard at Instagram. We're everywhere, guys. So let us know what you like, comment, subscribe, share this everywhere you possibly can. And you know how I end it every time, guys. You don't have to be a pharmacist. You don't have to work in the ED. But everything you do, make sure you pharm so hard.
Weezy out of here.